Hello, everyone. Thank you for joining us today. I'm so glad to see you all here for Continental League of Megamind 2024. My name is Miss Kannika Bureekanchan, graduated from Prince of Songkhla University, Thailand. Today, I will present an immediate implant placement in an infected socket site in aesthetic area. Let's get started. Thai female patient, 59-year-old. The patient came with chip complaint, tooth 21 porcelain filled to metal crown dislodgement, and tooth 11 gingival recession exposed crown margin. Patient denied any medical disease and drug allergy. There is no problem with previous dental treatment. When examining tooth, it was found that tooth 21 porcelain filled to metal crown dislodgement with metal post, central upper incisor supra-eruption, root surface exposed about 1 mm. Gingival recession, thick biotite, sensitive to percussion, no pus and exudate, and no tooth mobility. This picture shows upper central incisor poor prognosis for re-restorable. Unlike lower picture show radiolucent area between tooth 11 and 21. From panoramic film show good contrast, symmetrical condyle, present radiolucent area between tooth 11 and 21 in maxillary bone, no positive pathology in mandibular bone. From clinical examination and radiograph of upper central incisor, a differential diagnosis can be made as follows: 1. Radicular cyst, 2. Lateral radicular cyst, and 3. Nasopalatine duct cyst. However, a biopsy must be confirmed. Therefore, this can be summarized as follows: problems and diagnosis. For tooth 11, the problem with this tooth is supra-eruption, gingival recession, tooth discoloration, and last periapical lesion. So the diagnosis of tooth 11 is unrestorable tooth and radicular cyst. And for tooth 21, the problem with this tooth is crown dislodgement, present rarified area, tooth discoloration, and supra-eruption. So the diagnosis of tooth 21 is unrestorable tooth. When trying to simulate the implant's dormant bone level taper diameter 4.1, length 14 mm on tooth 11, it was found that the implant engaged apical bone about 2 to 3 mm, with the implant platform position 4 mm from gingival margin where the final prosthesis. And tooth 21 also used an implant's dormant bone level taper diameter 4.1, length 14 mm too. It was found that the implant engaged apical bone about 6.49 mm. This picture also shows the final position of implants, tooth 11 and 21. A 2015 study by Shakanovic et al. Found that several studies support immediate implant placement of teeth with periapical lesion or periodontal disease can be successful in osseointegration. But before implantation, the socket must be debridement and cleaning the socket before implantation. This is consistent with a study by Esthetic et al. In 2016 that found immediate implant placement for teeth present periapical lesion or periodontal disease. This can be done safely if the socket is cleaned well. And from a study by Esthetic et al. In 2016 showed the survival rate of implant placement into infected site was 98.4% plus or minus 0.9%. In this case of tooth 11, it was found that apical implant engaged maxillary bone about 2 to 3 mm, which was unable to restore the provisional crown. Therefore, primary closure was needed, such as socket seal surgery. Nowadays, there are many types of material used for socket seals, including free gingival graft, collagen matrix, collagen sponge, and cellular matrix, polytetrafluoroethylene membrane, and individualized healing abutment. Most recently, Fabro et al. In 2022 systematic review has suggested that socket seal surgery using soft tissue or various materials can reduce hard tissue chains better without socket seal surgery. At the same time, Kannika et al. In 2022 discovered that soft tissue graft preserve the horizontal ridge better than other types of membranes. Pre-gingival graft is an option that is popular in making socket seal surgery because 1. Reduce shrinkage of the soft tissue architecture. 2. Addition soft tissue volume. And 3. Reduce the dimensional change. Therefore, a treatment plan with 3 options has been proposed for treating patients as follows. Option 1. Radicular-seed enucleation with upper central incisor, immediate implant placement with socket sealed. The advantages are preserved IDP, short treatment time, patient satisfaction, and preserve hard and soft tissue. Option 2. Radicular-seed enucleation with upper central incisor socket preservation and socket seal. The advantages are preserved hard and soft tissue. And option 3, radicular-seed enucleation and upper central incisor extraction for waiting early implant placement with GBR. So when talking with the patient should option 1. Well, it's time for implant surgery. A traumatic teeth extraction with enucleation and socket debridement complete. No labial bone perforation. A biopsy from tooth 11 was sent for pathology examination. Both teeth immediate implant placement with gap grafting at tooth 21 and tooth 11 defect grafting with xenograft. Socket seal surgery with pre-gingival graft that harvest from the left palatal side. This picture shows immediate post-op of panoramic film. This picture shows immediate post-op of periapical film. And this picture shows immediate post-op of CBCT. After 3 days, you will observe that the pre-gingival graft is beginning to turn red, indicating a high likelihood of pre-gingival graft survival. Follow up 7 days, confirm that pre-gingival graft will definitely survive. While waiting for the disc-off, it was found that the biopsy results were known to be a reticular-seed. Follow-up 14 days found that tooth 11 pre-gingival graft complete survive and tooth 21 partial necrosis in the central of pre-gingival graft. Follow-up 1 month. Follow-up 1.5 months. Follow-up 2 months. Follow-up 4 months. I start the second stage of surgery to get a provisional crown after implant placement for 6 months. This picture shows clinical and radiographic post-operative in 6 months. Panoramic film post-operative in 6 months. And CBCT post-operative in 6 months. For the flap design of stage 2, the design is paracrestal at tooth 11 and 21 area and vertical incision at tooth 11 mesial side and 21 mesial side. After that, I tried in temporary abutment of both teeth. And I decided for create distal papilla at tooth 11 distal side and 21 distal side by split finger flap. From the slide is where the white arrow point. After that, I suture the finger flap with gingival at palatal area of tooth 11 and 21. This suture must be a butt joint technique. Until suture complete and temporary crown shown in this picture. I was total stitched off 2 weeks after tooth surgery. Waiting for the complete soft tissue healing for about 6 weeks, I made an appointment for the patient to final impression. I decided the final crown to be layering zirconia crown with varioble abutment of tooth 21 and angle screw of tooth 11. After I removed the temporary crown, the soft tissue looked good, healthy, and ready for the final restoration. This picture shows follow-up 2 weeks after final crown delivery. Everything looks good. Follow-up 1 month. And follow up 1 year after crown delivery, everything looked good. And this is a very long journey of this patient. She was very happy to have these both teeth. Conclusion, immediate implant placement in infected site. Advantages. 1. Reduce treatment time. Combine extraction and implant placement in one visit. 2. preservation of bone and soft tissue, maintain oral lid and gingival architecture. 3. Enhances aesthetics. Immediate implant placement can lead to better aesthetic outcome. And 4. Patient convenience. Fewer surgical procedures and shorter overall treatment duration. For disadvantages, 1. Higher risk of infection. Infected site may increase the risk of implant failure. 2. Complex surgical procedure require high surgical skill and precision. 3. Uncertain initial stability. Infection may affect the initial stability of the implant. And 4. Needs for antibiotic. Increase reliance on antibiotic to manage infection site. Thank you for your attention.